The hallmark of cyanotic congenital heart disease is a right-to-left shunt. Blood bypasses the lungs, so systemic circulation receives deoxygenated blood mixed with oxygenated blood. This mixing is what lowers arterial oxygen content and makes cyanosis possible. It only becomes visible when at least 5 grams per deciliter of hemoglobin is desaturated. That threshold explains why an anemic infant can be profoundly hypoxemic without looking cyanotic, while a polycythemic infant may appear cyanotic at higher saturations. Cyanosis is most evident centrally, on the lips, tongue, and mucous membranes, because these sites best reflect arterial saturation. Peripheral cyanosis, by contrast, often results from local vasoconstriction or low cardiac output rather than true arterial desaturation. For cyanosis to be obvious, oxygen saturation usually needs to fall into the 75 to 85% range, and central cyanosis becomes apparent when saturation drops below roughly 80 to 85%. These thresholds explain why a neonate may initially look pink despite significant shunting, only to become visibly cyanotic as oxygen delivery falls further. The central feature of cyanotic lesions is how blood crosses from the right side of the circulation into the left without passing through the lungs. This can occur through mixing lesions such as atrial septal defects, ventricular septal defects, or great vessel connections, where oxygenated and deoxygenated blood blend within a common chamber. It can also occur through obstructive lesions, where elevated pulmonary vascular resistance or outflow obstruction limits pulmonary blood flow and forces systemic venous return across a defect into the systemic side. The balance between pulmonary and systemic vascular resistance determines the degree of right-to-left shunting. When pulmonary resistance remains higher than systemic resistance, blood preferentially bypasses the lungs and arterial desaturation becomes severe. Over time, compensatory responses emerge. Chronic hypoxemia stimulates erythropoiesis, producing polycythemia that improves oxygen-carrying capacity, but also increases blood viscosity and thrombotic risk. Long-standing cyanosis leads to digital clubbing, reflecting vascular and connective tissue changes from chronic hypoxemia. At the same time, metabolic demands rise, and infants often struggle to match oxygen delivery to growth needs, which explains why growth failure and poor feeding are common. Clinical evaluation is essential for distinguishing cyanotic heart disease from primary pulmonary disease. The Hyperoxia test is a cornerstone. In congenital heart disease, oxygen saturation changes very little, even with 100% inspired oxygen, because the limitation is not ventilation, but shunting. Pre- and post-ductal saturation measurements add further diagnostic value. Differences between upper and lower body saturations suggest ductal shunting or transposition physiology. Feeding and exercise tolerance provide physiologic insight. Infants with fixed cardiac output fatigue quickly during feeding because metabolic demands exceed the limited capacity for oxygen delivery. Growth is often impaired for the same reason. Chronic hypoxemia raises energy requirements while simultaneously restricting intake. Neurologic development is also at risk, since prolonged hypoxemia compromises cerebral oxygenation during critical developmental windows. 4-extremity blood pressures should always be obtained. Differences may point to obstructive lesions, such as coarctation, or highlight systemic malperfusion that contributes to cyanotic presentation. When combined, these assessments provide a rapid framework for narrowing the differential and prioritizing urgent interventions. The classic cyanotic lesions are remembered as the 5 T's. Truncus Arteriosus is the first, a single trunk leaving the heart that supplies systemic, pulmonary, and coronary circulations, almost always with a ventricular septal defect. Second is transposition of the great arteries, where the aorta and pulmonary artery switch connections, creating parallel rather than serial circulations. Third is tricuspid atresia, a defect where the tricuspid valve is absent, producing single ventricle physiology dependent on interatrial and often interventricular communications. Fourth is tetralogy of Fallot, defined by 4 cardinal features: ventricular septal defect, right ventricular outflow obstruction, overriding aorta, and right ventricular hypertrophy. The fifth is total anomalous pulmonary venous return, where pulmonary veins drain into systemic venous structures instead of the left atrium, creating obligatory right-to-left shunting. A simple way to commit these to memory is to use the hand as a guide. The first finger represents truncus, a single trunk. Two fingers together represent the two great vessels transposed. The third finger recalls tricuspid atresia, tree for three. The fourth finger signifies tetralogy with its four classic features. And the fifth finger corresponds to total anomalous pulmonary venous return, 5 words to complete the set. This pattern links anatomy with number and creates a durable anchor for recall in both clinical reasoning and teaching. Truncus arteriosus is defined by a single large arterial trunk arising from the heart that supplies the systemic, pulmonary, and coronary circulations. Instead of separate outflow tracts, both ventricles empty into this common vessel. A large ventricular septal defect is always present, creating a direct mixing site at the ventricular level. The result is that oxygenated and deoxygenated blood combine before leaving the heart, and distribution depends on relative resistances in the systemic and pulmonary circuits. The truncal root gives rise to the aorta, pulmonary arteries, and coronary arteries, so one channel carries the full burden of cardiac output. Clinically, this explains why cyanosis is usually present but variable, and why excessive pulmonary blood flow contributes to heart failure in early infancy. This defect illustrates the principle that without separation of circulations, the body cannot maintain normal oxygen delivery, and the risk of pulmonary vascular injury begins almost immediately after birth. The Van Praagh classification organizes Truncus arteriosus based on how the pulmonary arteries originate from the common trunk. In type A1, the pulmonary arteries arise from the left side of the truncal root. In type A2, they arise from the posterior wall of the truncus. In type A3, one pulmonary artery comes off the truncus while the other originates from the aortic arch, creating asymmetry and surgical complexity. Type A4 is the most severe form, with absent native pulmonary arteries, functionally resembling an extreme variant of tetralogy of Fallot, dependent on collateral supply. This system matters because it guides operative planning. Surgical repair requires establishing a reliable pulmonary outflow and knowing whether one or both pulmonary arteries connect directly to the truncus, or whether reconstruction is necessary, determines the operative approach and prognosis. Classification also predicts long-term complications, as unusual origins or absence of pulmonary arteries increase the risk of pulmonary hypoplasia and reintervention. Truncus arteriosus frequently occurs in the context of broader developmental abnormalities. The most important association is the 22q11.2 deletion, or DiGeorge syndrome. Recognition of this genetic link is clinically important because affected infants may also have thymic hypoplasia, immune deficiency, and hypocalcemia, which all impact perioperative management. The truncal valve itself is often abnormal, and regurgitation can create wide pulse pressures and worsen heart failure. Additional associations include aortic arch abnormalities and coronary artery anomalies, both of which complicate surgical repair. While Truncus arteriosus usually presents as an isolated cardiovascular lesion, the presence of these associated conditions determines operative risk, long-term prognosis, and the need for genetic counseling. Identifying them early ensures that management strategies address not only the structural heart defect, but also the systemic features that may complicate care. In Truncus arteriosus, both ventricles empty into a single arterial trunk through a large ventricular septal defect, so systemic and pulmonary circulations are completely mixed. Because pressures in the truncus are high, both ventricles experience volume and pressure overload, leading to early ventricular dilation and dysfunction if untreated. As pulmonary vascular resistance naturally falls after birth, more blood is shunted into the pulmonary arteries at high pressure, producing excessive pulmonary blood flow. This accelerates the development of pulmonary vascular disease and contributes to congestive heart failure in the first weeks of life. The degree of cyanosis varies depending on how much blood preferentially enters the pulmonary arteries versus the systemic circulation. When pulmonary flow is excessive, cyanosis may be mild, but heart failure is prominent. When pulmonary flow is restricted, cyanosis becomes more pronounced. This dynamic explains the clinical variability at presentation and why most infants deteriorate quickly without surgical intervention. Newborns with Truncus Arteriosus often have only mild cyanosis at birth because pulmonary vascular resistance is still high and limits shunting into the lungs. As resistance falls over the first 6 to 8 weeks, pulmonary blood flow rises sharply, leading to signs of congestive heart failure. Tachypnea, poor feeding, and growth failure develop as the infant's metabolic demands outpace effective oxygen delivery. Respiratory distress progresses as pulmonary overcirculation worsens, and without surgical repair, clinical status deteriorates rapidly. The degree of cyanosis varies according to the balance of pulmonary and systemic blood flow. Some infants appear relatively pink with severe heart failure, while others demonstrate more obvious cyanosis when pulmonary flow is limited. This variability underscores the importance of recognizing that Truncus arteriosus presents not only with cyanosis, but also with early and progressive heart failure. Physical findings in Truncus arteriosus reflect both cyanosis and heart failure. Central cyanosis is usually present, but may be subtle if pulmonary blood flow is high. A harsh systolic murmur is common, produced by flow across the ventricular septal defect or outflow tract. And the second heart sound is characteristically single because there is only one semilunar valve. The precordium is hyperdynamic, reflecting volume and pressure overload of both ventricles. Signs of congestive heart failure, such as hepatomegaly and peripheral edema, develop as pulmonary overcirculation increases. Wide pulse pressure is a key finding when truncal valve regurgitation is present, and chest radiography typically reveals cardiomegaly from chamber enlargement. These physical examination features help distinguish Truncus arteriosus from other cyanotic lesions and highlight the combined impact of volume overload, abnormal valve function, and systemic to pulmonary shunting. Medical therapy for Truncus arteriosus is directed at controlling heart failure and supporting growth while awaiting surgical repair. Diuretics reduce pulmonary congestion and relieve symptoms of volume overload. Angiotensin-converting enzyme inhibitors lower afterload and improve forward output, while digoxin may provide modest inotropic support. Because these infants expend tremendous energy on breathing and feeding, high-calorie nutrition is critical to prevent further growth failure. Pulmonary artery banding was historically used to limit overcirculation when surgery was delayed, but it is rarely employed now given the risks of worsening ventricular strain. The key principle is that medical management is supportive and temporary. Without timely surgery, the physiology progresses to irreversible pulmonary vascular disease and declining ventricular performance. Definitive treatment for Truncus arteriosus is early surgical repair, most commonly with the Rastelli operation. Timing is critical, ideally between 6 and 12 months, to prevent irreversible pulmonary vascular disease from sustained overcirculation. The procedure has 3 key components. The ventricular septal defect is closed so that the left ventricle ejects solely into the truncal root, establishing systemic output. If the truncal valve is regurgitant, it is repaired at the same time to restore competence and reduce wide pulse pressures. Finally, a conduit is placed from the right ventricle to the pulmonary arteries, creating a separate low-pressure pulmonary circuit. This separates systemic and pulmonary circulations for the first time. Long-term considerations include conduit replacement as the child grows, often requiring multiple reoperations through adolescence and adulthood. Despite these challenges, early complete repair provides the best chance for survival and functional outcomes, while delay leads to progressive pulmonary vascular damage and poor prognosis. In transposition of the great arteries, the ventriculo-arterial connections are reversed. The aorta arises from the right ventricle, while the pulmonary artery arises from the left ventricle. This creates 2 parallel circulations, rather than the normal series circuit. Deoxygenated blood returns to the systemic venous side, passes through the right ventricle, and is pumped back into the aorta without oxygen exchange. At the same time, oxygenated blood from the lungs recirculates from the left ventricle back into the pulmonary artery. Survival depends entirely on mixing between these circuits, whether at the atrial level through a patent foramen ovale, at the ventricular level through a septal defect, or at the ductal level through a patent ductus arteriosus. This lesion is the most common cyanotic heart defect presenting in the newborn period and shows a strong male predominance. The severity of clinical presentation is directly related to the adequacy of mixing. When intercirculatory communication is limited, cyanosis and acidosis develop rapidly, making immediate recognition and intervention essential. Two distinct anatomic forms of transposition are recognized. The first is simple or dextrotransposition, in which the great arteries are switched, but atrioventricular connections remain normal. About 60% of these cases have an intact ventricular septum, while 40% include a ventricular septal defect. Roughly 10% have left ventricular outflow obstruction, which alters the physiology and can affect timing of intervention. The second form is congenitally corrected or levotransposition. In this variant, there is both ventriculo-arterial and atrioventricular discordance, sometimes called double discordance. Blood flow is physiologically corrected, but the right ventricle supports the systemic circulation. Associated defects are common, including ventricular septal defects in up to 70% of cases, left ventricular outflow tract obstruction in about 1/3, and abnormalities of the tricuspid valve such as Epstein-like dysplasia with regurgitation. Progressive conduction system disease is another hallmark, and complete heart block is a frequent long-term complication. These distinctions are clinically important because simple DTGA presents with profound cyanosis in the newborn period, while LTGA may remain undiagnosed until later due to physiologic compensation, but carries long-term risks related to systemic right ventricular function and arrhythmias. The fundamental problem in transposition is that the systemic and pulmonary circulations run in parallel instead of in series. Deoxygenated blood cycles repeatedly through the body, while oxygenated blood loops back to the lungs. For systemic oxygen delivery to occur, there must be a site of mixing. The atrial level is most common through a patent foramen oval or atrial septal defect. A ventricular septal defect, if present, allows additional mixing, and a patent ductus arteriosus can also provide critical communication between the circuits. The degree of cyanosis depends on how effective this mixing is. When mixing is limited, systemic oxygen saturation falls precipitously, and metabolic acidosis develops within hours of birth. When larger communications exist, oxygen delivery improves temporarily, but the price is volume overload and risk of congestive heart failure as pulmonary vascular resistance falls. This explains why infants with intact ventricular septum are the most critically ill, while those with associated ventricular septal defect may present later with heart failure in addition to cyanosis. Infants with transposition present with severe cyanosis within hours of birth, particularly as the ductus arteriosus begins to close and mixing diminishes. Tachypnea and poor feeding are common early signs as limited oxygen delivery stresses both metabolic and cardiovascular systems. Some infants appear relatively stable for a short period if they have generous intercirculatory mixing, but deterioration is inevitable once that communication narrows. A unique clinical clue is reversed differential cyanosis, where saturations are paradoxically higher in the lower body than in the right arm during the first hours of life, reflecting flow patterns through the ductus and great vessels. Cardiac examination is often deceptively normal, with the main finding being a loud single-second heart sound from the anteriorly positioned aorta. Electrocardiography may show right atrial enlargement and right ventricular hypertrophy, reflecting systemic venous return and output through the right ventricle. Recognizing this presentation quickly is critical, because without prompt intervention, profound hypoxemia and systemic acidosis develop and are incompatible with survival. The clinical picture in transposition depends on the associated anatomy. When the ventricular septum is intact, mixing is limited to the atrial level, producing the most severe cyanosis. These infants require urgent intervention within hours to days of birth. In contrast, when a ventricular septal defect is present, oxygenated and deoxygenated blood mix more effectively. Cyanosis is less severe initially, but as pulmonary vascular resistance falls, left-to-right shunting through the ventricular septal defect increases, leading to pulmonary overcirculation, congestive heart failure, and eventual pulmonary vascular disease if untreated. A third variant occurs when transposition is combined with pulmonary stenosis, which mimics the physiology of tetralogy of Fallot. Cyanosis is persistent, but relatively stable because restricted pulmonary blood flow prevents excessive overcirculation and protects the pulmonary vasculature. These infants may require palliative systemic to pulmonary shunts to maintain adequate oxygenation until definitive repair is possible. The spectrum of presentation reflects how the presence or absence of additional lesions alters the balance between mixing, systemic oxygen delivery, and pulmonary blood flow. When transposition occurs with both a ventricular septal defect and pulmonary stenosis, the physiology shifts toward that of tetralogy of Fallot. The ventricular septal defect allows essential mixing, so cyanosis is not as immediately life-threatening as in simple transposition. At the same time, pulmonary stenosis restricts pulmonary blood flow, which prevents the excessive overcirculation and heart failure seen in transposition with a large ventricular septal defect alone. The result is a relatively stable but persistently cyanotic clinical course. These infants remain protected from early pulmonary vascular disease because high pressures are not transmitted continuously to the pulmonary arteries. However, the trade-off is chronic hypoxemia, which can impair growth and increase risk of complications such as polycythemia. Some patients require a systemic to pulmonary artery shunt to augment pulmonary flow until definitive surgical correction can be undertaken. This variant highlights how associated lesions can dramatically alter the trajectory and timing of intervention in transposition. Emergency management of transposition focuses on maintaining adequate mixing between the parallel circulations. Prostaglandin E1 infusion is the first step, as it preserves ductal patency and allows blood to cross between the great vessels. Typical dosing is 0.03 to 0.1 micrograms per kilogram per minute. Apnea is a frequent side effect, so preparation for intubation and ventilatory support is essential. If interatrial communication is restrictive, balloon atrial septostomy, also called the Rashkind procedure, provides immediate relief. By enlarging the foramen ovale, left atrial blood can cross to the right atrium, improving systemic oxygen delivery. This intervention stabilizes the infant and serves as a bridge to definitive surgical repair. Timing is critical, and septostomy is often performed within the first 24 to 48 hours of life, when oxygenation cannot be sustained with prostaglandin alone. These measures do not correct the defect, but provide vital stabilization until an arterial switch operation can be undertaken. The definitive operation for transposition is the arterial switch procedure. In this repair, the aorta and pulmonary artery are resected and reattached to their appropriate ventricles, restoring normal series circulation. The most technically demanding step is transferring the coronary arteries to the neo-aorta, as malposition or injury can compromise myocardial perfusion. When performed in the first weeks of life, before the left ventricle regresses from pumping only to the low-resistance pulmonary circuit, this operation offers excellent survival and long-term functional outcomes. Historically, atrial switch procedures such as the Senning and Mustard operations were performed. These redirected systemic and pulmonary venous inflow at the atrial level, allowing physiologic correction but leaving the right ventricle as the systemic ventricle. Over time, this strategy led to progressive right ventricular failure and arrhythmias. Today, atrial switch is reserved for rare cases where arterial switch cannot be performed, such as when coronary artery anatomy makes transfer unsafe. For most infants, early arterial switch remains the standard of care, providing the best chance for durable normal physiology. Long-term survival after arterial switch is excellent, with more than 95% of patients alive at 20 years. Functional outcomes are generally good, allowing most children to grow and develop with minimal limitations. Nonetheless, ongoing surveillance is essential. Coronary artery stenosis or occlusion may occur due to the complexity of coronary transfer, and this risk persists throughout life. Outflow tract obstruction can develop at either the neo-aortic or neopulmonary level, requiring reintervention. Arrhythmias are possible, but relatively uncommon compared with historical atrial switch repairs. For those who underwent the older atrial switch procedures, complications are more frequent. The systemic right ventricle gradually loses efficiency, leading to dysfunction over time. Atrial arrhythmias, including atrial flutter and fibrillation, are common, and exercise tolerance is often limited. These differences highlight why arterial switch has become the standard of care. It not only restores normal physiology, but also provides durable outcomes when performed early, with far fewer long-term complications than its predecessors.